Welcome to the Lifestyle Medicine Podcast, where my goal is to connect everyday people with health professionals who offer evidence-based advice on disease prevention and utilise science to help you live a healthy and happy life. Dr Chris Conyard, welcome to the Lifestyle Medicine Podcast, mate.
Thank you, mate.
So from here on in, you'll be known as Chriso because you and I go way, way back. But today, the purpose of the chat is just to sit down, have a bit of a casual chat about what you do and as a health professional, and also we're going to talk about bone health and in particular osteoporosis. So this is our third attempt at this podcast because we've had a few technical issues. So why don't you start by telling everyone and giving them a background as to what you do in your daily practice and where you're at within all your training.
Thank you, mate, and thanks for having me on. So I started studying health about 15 years ago when you and I embarked on an exercise science and physiotherapy degree back when we were young and wild and free. And from there, I went on and did medicine. And then after medicine, worked as a doctor for a couple of years and then got on the orthopaedic training program after about 6 years of being a doctor. And then I just finished my orthopaedic training last year, finished the final exam. Still sitting exams as a 36-year-old bloke's a pretty humbling experience. And then and now I'm actually in New Zealand just doing a bit of extra orthopaedic training. I'm going to specialise in the upper limb, so sort of shoulder, elbow, hand.
Yeah, so I just want to take you back because I personally am fascinated by your story, and I have always been super proud of you as a human. But you grew up in Grafton, in a smallish city, the Lower Clarence or the Upper Clarence back there, and you. This is really important for people, I think, to hear about how you got to where you are, because you worked harder than anyone I ever know. But you sat your high school certificate and you didn't get the marks to get into exercise science, and you went into health science. Is that right, at Griffith Uni?
Yeah, so I wanted to do physio, but the mark to get into physio was 99. And yeah, I grew up in Grafton, and Grafton is beautiful a place as it is, you don't get that much guidance through high school. And the way when we sat the final exams in year 12, each subject was weighted a certain way, and if you don't get guidance on what subjects to do, it doesn't really matter how well you go in the exam, you're not going to get a good mark overall. So yeah, I didn't get the marks for physio, and then that year exercise science was reasonably high, so I didn't get the marks for that as well. So I got into health science, and that was all with the view to pick subjects that I could transfer across into exercise science and still finish in the same amount of time. So I got pretty lucky. I sort of did reasonably well at the first couple of years of uni, and then managed to transfer in exercise science after 1 year and physio into 2. And I still managed to finish physio and exercise science double degree in 5 years, which is what it would have taken me if I got straight in anyway. And I think probably the lesson is just once you get into uni, it's much easier to transfer laterally from there than getting into from high school.
Yeah, and I noticed you said you got lucky, but you worked damn hard, and it's amazing, mate. I look back to where you are now. I think it's such a good example for anyone who thinks about doing medicine. Like I remember when we were training in physio, and we thought, we would never be doctors or anything like that. And then here we are a couple of years later, well, decades later, I should say, still sitting exams. You hit the nail on the head. So you're over in New Zealand now. You're doing a fellowship. You're a fully qualified consultant in Australia, but you've elected to go and do some extra training, and you're in New Zealand. And I know you've shipped up your family and uprooted the roots, and you've gone over to New Zealand, and it's been quite hard, but it's going to be bloody amazing because you're doing an upper limb fellowship. Is that right?
Yeah, it is funny. I've got wife and 2 young children, another one on the way. And after New Zealand, we're going to the UK for 6 months. And I originally sold it to Connie, my wife, as, we'll have this romantic European getaway. And the reality is we've realised that we're going to be in the north of England in the middle of winter with 3 young kids. It's not going to be as romantic as I sold it, but
all right, mate. Well, let's get into it. So we're going to talk about osteoporosis. So you see osteoporosis every day. I guess the whole premise behind this podcast is that people like you and me, we see disease every day. And by virtue of that, I truly believe that, I know your values. We try and stay as healthy as we possibly can. So let's talk about osteoporosis, the disease process, and then how we prevent it. So what is osteoporosis to you?
So osteoporosis is it's a quantitative disease of bone, and by quantitative I mean if you've got osteoporosis, you've got normal bone, just not as much of it as you previously did. So the maximum amount of bone, or the maximum density of bone we've got, is around sort of the mid-20s. And as just a natural part of aging, our bone becomes less and less dense. It happens sort of over the age of 50 generally. And yeah, it's a disease of the amount of bone that you've got.
Yeah, and from my understanding and my limited understanding, going back to my physio days, osteopenia is a bit of a continuum towards osteoporosis. Just to, I guess, define some terms for the listeners as well.
Yeah, so it's a continuum of disease from normal bone, and normal bone is. So I suppose that brings us to the way that it is diagnosed, and it's diagnosed with a thing called a bone mineral density test, or a DEXA scan, which is dual energy X-ray, and that just measures the density of your bone. And when you measure that density of bone, that comes out with a number, and then you compare that to what is normal for you based on gender and race, because everyone has different bone densities. And if you're more than one standard deviation from normal, which is, in the 5th centile, so a long way from normal, you've got osteopenia. And if you're more than 2.5 standard deviations, you've got osteoporosis. So yeah, it's a continuum.
Right. So we'll talk about DEXA scans a little bit down the track. We'll just touch on the burden of disease. So being an anaesthetist, you orthopods always continually bringing me sort of hip fractures and all sorts of fun things to anaesthetize. And what's the burden of this disease? Why is it important? Why should people be aware of osteoporosis?
It's quite significant. It's so in Australia, about 2 out of 3 people over the age of 50 have bone that would meet the quality of osteopenia, at least. Not necessarily osteoporosis, but osteopenia. And in Australia, at the moment, there's about 500 fractures per day that are directly as a result of osteoporosis. And a fracture, like, we think it's pretty important because that's all we deal with as bone doctors. But a fracture can be a life-changing event in one of these patients. It certainly, I'm sure we'll talk about it, but if you fracture your hip as an elderly patient, that is a life-changing event. It's not just a hip fracture. It's a sort of a sign that things are not going very well for you. So there is quite a significant burden, yeah.
Yeah, so let's talk about that then. Let's talk about, because hip fractures are probably the most common osteoporosis. Is that right? Is that probably the most common?
It's the second most common. The most common is actually vertebral fractures. So
right.
Osteoporotic vertebral fractures, usually in the thoracic spine. But then hip fractures are second, and wrist fractures are third.
Okay. Well, let's talk about hip fractures, because you'll see this in I guess a lot of elderly people, and it's typically elderly females. And we'll talk about those risks, but when they do fall over, my understanding is that there's quite a significant mortality rate following that fall. What are your thoughts on that?
Yeah, definitely. So the mortality rate after a neck or femur fracture is about 25 to 30% at 12 months.
Yeah.
So that's, if you, and sometimes these are patients that are previously independent. They fall and break their hip, and then 1 in 4 of them will die within 12 months. So that's a significant event. It also really impacts their independence and their mobility, and this is probably related to the mortality. So we tell people, if you've broken your hip, you will lose 1 level of independence. And what that means is, if you were previously independently mobile, so you walked around without any gaits or aids, you'll probably need a walking stick. And if you needed a walking stick, you'll probably need a hopper frame or a 4-wheeled walker. And if you needed a 4-wheeled walker, you'll probably be wheelchair bound.
Yeah. And then in nursing home dependent, essentially, at some stage as well. Yeah.
Exactly.
Yep. So on that, we're talking about thoracic fractures as well. That's not something I'm super familiar with. How are these sort of how are these fractures presenting, and who are getting these fractures?
These fractures are generally in postmenopausal females, and the reason for that is estrogen has quite a significant protective effect with bone. It is required with bone turnover and bone mineralization. So if you lose your endogenous estrogen, or the estrogen that you produce, then you're at significant risk of osteoporosis. And that's why females have hormone replacement therapy, one of the reasons. So in postmenopausal females, and then about 1/4 of these patients are males over the age of 70.
Yeah, right. And is it quite significant, the burden of the disease for the thoracic fractures, or is that something? My understanding of vertebral fractures is, as long as it's stable, it's okay. But I'm assuming is there something that these people should be worried about?
Yeah, so they most commonly are stable, and the treatments we've got aren't that good, to be honest. So we've tried a number of things to treat these, including squirting cement into the vertebral body or blowing them up even with balloons, which sounds a bit wild, but none of these things seem to work very well. So you're right, most of the time we just diagnose it and then monitor it serially with x-rays over a period of time. But the vast majority of time, these patients don't need any formal treatment.
All right.
From a certain perspective.
Yeah, right. Okay. And is that, I'm assuming that's not it for them. So I'm assuming there's going to be a lot of lifestyle things, but is it, once they have these fractures and they're being monitored, do you then start to push lifestyle factors and things like that as well?
For sure. So this is the most commonly way that osteoporosis is diagnosed. They present with a pathological fracture. And by pathological, that just means that they've fractured through abnormal bone, which is osteoporosis. So they might present with back pain. They get an x-ray. It shows a compression fracture through osteoporotic bone. That is when we refer to the GPs, who are really the keys behind the treatment of this, for modifying any modifiable risk factors and looking at any potential pharmacological or non-pharmacological intervention.
Yeah, perfect. And you just touched on that then. We were just going to talk about symptoms for these people. And you were saying that the most common presentation is to have that fracture. Is there any other sort of symptoms that these people have?
Not really. It's a silent disease. And that's the problem. People don't know they've got osteoporosis until they have a simple fall from a standing height. And because their bone isn't of the quality that it can absorb that fall, they fracture. And that is the only way that they find out they've got osteoporosis.
Yeah, and I see people's faces when they're coming to theatre, and it's quite often an elderly, a grandmother or someone who, and the children of that patient, how did this happen? And they're really blown away by the impact of this disease, and they just think, like you said, it's a silent disease. It just happens, and all of a sudden they're just taken aback as to what's involved in this huge process from there on in.
Yeah, exactly.
So, mate, diagnosis, we touched on DEXA scan. So these people obviously present and then they have their hip fracture and things like that. Do they then go on to get DEXA? What's the workup from then? How do we diagnose osteoporosis?
So there is a screening process, and in Australia, screening involves females that are postmenopausal over the age of 50 and sometimes males over the age of 70. And if they are screened and found to be osteopenic or osteoporotic, there are multiple lifestyle interventions that the GPs will initiate and refer to the appropriate allied health practitioners. And if it's severe enough or refractory to that sort of treatment, that you can give there are bisphosphonate type medications or even other medications that you can get now that you only need an injection once every 6 months. But again, these are for patients that are refractory to lifestyle intervention. Just to try and prevent the burden of an osteoporotic fracture. Yep.
So I guess treatments wise, and I'm not sure if you deal with it as much, but I guess we've got the bisphosphonates, and then there's some sort of depot injections. I can't really remember the name of them. Do you know much about them?
Oh, a little bit. So there's some of them that work based on estrogen. So they're all about optimizing the mineralization of bone. And the beauty of them is they've got such a long half-life that you only need an injection once every 6 or even every 12 months.
Yeah, perfect.
The problem, but they're not as benign as they may seem. There are side effects, and one of the side effects that we see is they can get these, paradoxically, they can get fractures of the femur as a result of these medications. And it's hard to treat then because these medications restrict the bone's ability to heal if a fracture does happen. So they're great to prevent fractures, but then if you fracture, it is a problem.
Yeah, right. That's the nuances of medical treatment, right? And this is what I find so fascinating about what we do is, I think you touched on it before. And when we do these surgical procedures or we give people medications, we're constantly monitoring these people. And I think a lot of people lose a bit of trust in the health system at times because we do have some complications and things, but we monitor them so closely, and that's the beauty of science and medicine, right? We're constantly adjusting and changing our practice based on the information we get. And I just think that people kind of lose sight of that sometimes, and they just think that, I'll look at all the complications that happen in the hospital. But the reality is we do so many amazing things for people, right?
Yeah, for sure. Yeah, for sure. And it's in my mind, it's all about educating the patient and giving them realistic expectations and not promising things that you can't deliver.
Yeah, yep. All right. So let's talk about some of the lifestyle factors that you'd sort of recommend. Oh, sorry. No, before we go into that, I've just got a couple of notes here that I'm checking out too. So let's talk about risk factors. We talked about hormones. So I guess menopause. So women over the age of 50 or post-menopausal, that's a risk factor. Is that right? What
Yeah.
about so let's touch on diet. What are your thoughts on diet and risk factors for that?
So, yep, for sure. So diet, so vitamin D and calcium are the two big things for osteoporosis and bone health, and they're very interrelated. Vitamin D deficiency is associated with not only low bone mineral density, but it's also associated with falls. And we don't really know why, but people that have low vitamin D have increased falls risk.
Yeah, right.
And if you piggyback that onto their lower bone mineral density, they're a higher risk of pathologic fractures. So optimizing vitamin D is certainly imperative in these people. And then calcium as well, just getting the recommended daily intake is very important. And in Australia, it's measured in international units. It's about 1,000 to 1,300 international units per day. And to put that into a bit of perspective, 100 mils of milk has got 120 international units. Or if you don't drink dairy like I don't, almond milk's got exactly the same, because non-dairy milks are fortified with calcium the majority of the time. Worth
Yeah.
checking, because some of the organic brands don't, but most of them are fortified.
Yeah, I can tell you Bonsoy is not fortified, and that's normally my coffee drink because it's so bloody delicious. But yeah, I think you're right. And you and I have had this conversation a few times. We think that there was a bit of data from that EPIC cohort which suggested that vegans who aren't drinking a lot of dairy and aren't eating a lot of cheese are a higher risk of hip fractures. I guess my take home message from that was that if you were in the healthy BMI range as a vegan, then and you're getting enough calcium, so you're drinking a fortified milk, which is probably the big thing there. You're drinking a calcium fortified milk with a bit of vitamin D as well. You're going to be absolutely fine. You got anything to say on that?
So it's probably worth talking about the EPIC trial, I reckon, just briefly. So EPIC,
Yep.
for those that don't know, it's a cohort of about 65,000 patients from the UK. They started collecting data in the mid-90s. And the unique thing about these patients is 50% of them were vegetarian or vegan. So it's a very good comparison for those of us that are interested in predominantly or exclusively plant-based diet. It found that vegetarians had an 11% increased risk of fracture, and vegans had a 50% increased risk of fracture. Now, if you look into that further, though, the majority of that increased risk was due to their vegetarians and vegans having a lower BMI. And that's something with the risk factors. It's one thing that increased weight is protective for, probably the only thing. But if you have a low BMI, which vegetarians and vegans often do, you have an increased risk of fracture. And it makes intuitive sense, because every step you take, your bones have to respond to the load that goes through them. If you're 100 kilos, your bones are going to be reasonably strong, to a point, compared to if they're only putting up with 40, 50 kilos. So the vegetarians and vegans then in the EPIC Oxford trial, if they've got a healthy range BMI, so, 20 to 25, and normal calcium and vitamin D levels, their fracture risk is almost the same. It's not quite, it's still a little bit higher, but almost the same as the meat eating cohort.
Yeah. Okay. Yeah. No, that's yeah, that makes total sense, mate. And so I guess then, the other thing that I sort of comes to mind then is people who are vegan and eating raw vegan diets, which I certainly would never ever recommend. You do tend to see them in very, very low BMI, and I certainly would 100% strongly avoid anyone raising kids on a plant-based diet to avoid a raw vegan diet for their children as well. So I think that's something that's just my observation on that anyway as well too.
What's raw vegan? What's raw vegan mean?
So raw vegan means you don't cook anything. So it's all just, you're eating, if you don't cook your carrots, you don't cook anything like that. It's all just, you just eat it in its raw form. Which, there's a reason why we cook our food. It helps break down the cell walls, and we absorb nutrients far more readily. So I think it doesn't make any sense for me. I always tell people just avoid a raw vegan diet because, especially for kids, they need high nutrients, high calories, and vegan diets are typically high nutrient but lower calories. So you do need those calories, and so I think it's very important to maintain that healthy weight range.
For sure.
Yep.
And for sure. And then with vitamin D, again, most things are supplemented, but you can get that through sunlight. The recommendation at the moment for sunlight is about exposing 15% of your body for 15 minutes per day, and that will get you adequate vitamin D. But vitamin D is imperative in calcium absorption, so you can't really, it's pointless eating all the calcium in the world if you don't have vitamin D. And again, a lot of things are supplemented with vitamin D, or fortified, sorry. But yeah, if you don't take fortified foods, or you're worried, 15% of your body, 15 minutes of sun will get adequate vitamin D.
Yeah, exactly. And in Australia, for all those listening to, is the cow's milk is fortified with vitamin D as well, but also vegan milks are fortified with vitamin D, but I believe it's vitamin D2, which isn't as, I guess, as good as vitamin D3, unfortunately. But as long as you're getting that, like you said, that sunlight, you've probably got a vitamin D fortified non-dairy milk, and you're getting the calcium, you should be absolutely fine. And you're in the healthy weight range.
For sure.
Yeah, perfect.
If you're a pasty redhead like me, make sure you wear sunscreen.
Yes, good point. Good point. So exercise. This is where I think it's probably right up there as well. So what are your thoughts on exercise, weight training versus cardio, things like that?
So yeah, again, exercise is very important for all health, obviously, as we know, but particularly for osteoporosis. With osteoporosis, there's really three goals of the exercise, I suppose. One is optimizing your bone strength. Two is optimizing the muscle strength, and three is falls prevention. So on number one, optimizing the bone strength, like we said before, bone it's a dynamic organ. It responds to the loads that are put through it, and that is independent of age. So you can be 1 year old or 100 years old, your bone will respond to the load you put through it. That's why if you go into space and there's no gravity, you're not putting any load, astronauts after 20 days come back osteoporotic. So yeah, that's why that is one of the rate limiting things of space adventure at the moment.
Yeah, right.
As a bit of a side note. So things to increase your bone strength are load-bearing activity. And the simplest example of that is jumping. So, you jump up and you land, that is load-bearing. Your bone will respond to that and strengthen. Two, muscle strength. So this is both, it prevents falls and it helps absorb some of the load if you do fall. So you imagine you've got two people that fall from a standing height. One is severely underweight. They land on their hip. There is nothing stopping the load between the ground and the bone. If you've got someone then that's got big thigh muscles and big glute muscles, they've got something that's going to absorb a lot of the load. So they're going to have a reduced risk of fracture. And then three, falls prevention. And the main exercises we do for that, interestingly, Tai Chi has very, very good evidence, and also just simple balance exercises. But the people to consult for this are exercise physiologists. And in fact, they've got guidelines on osteoporosis and exercise that are out there.
Yeah, perfect. And you and I have sort of, I guess, been pretty heavily involved in the physio exercise realm. And And I know Ben Weeks, one of our old senior lecturers, did a study on kids just jumping off blocks. Have you read that study? I actually haven't read it, but do you know
Not
the
for
one?
time, but I did read it. Yeah.
Yeah, so children were jumping off a block at school like 30 times or something, and significantly increase their bone mass density. Is that right?
Yeah, exactly.
Okay, and then they went on then to do another study that I was involved with some of the very preliminary research on it in terms of validating a couple of strength tests. So the Lift More program. Have you been involved in that? Have you read about that? The data on that?
No, no.
No, so the Lift More program essentially was just looking, I think it was postmenopausal women. They were doing deadlifts and some squats and some really quite heavy lifting. And it's just amazing. They got some really good results. So something we could probably talk about it another day. Okay, so we've been through all those. Let's talk about, so diagnosis, DEXA. We talked about, so how to diagnose. So DEXA scan, you just go to your GP to get your a DEXA scan, is that right?
Yeah, for sure. It is to get it publicly funded, you've got to meet certain criteria. But I would certainly suggest if you're a postmenopausal female or a male over the age of 70, definitely talk to your GP about this. I'm sure your GP will be the one that'll bring it up. Or if you had a fracture or a broken bone from something you wouldn't expect to have a broken bone, if you crash your car and you break your wrist, sure, that's expected. But if you just fall from a standing height and break something, your bone's probably not normal. So it would be at least worth talking to your GP about and getting a DEXA scan. Otherwise, if you're at risk. So we've talked about really, there's two types of osteoporosis we probably should mention. The first is primary, which is the one we've been talking about the whole time. The other is secondary, which is where someone may have a hormonal abnormality. And this is rare. It's less than 4% of people with osteoporosis in Australia. But if you've got a family history of young people with osteoporosis, it's probably worth talking to your GP as well.
Yeah, and where does sort of steroids fit into that? Does that fit into secondary or
Secondary?
Yeah, secondary. So that's another cause for it. People have been on long-term steroids, prednisone, and things like that.
Exactly.
Okay.
Yeah.
Yep. So we've got about sort of 8 minutes left. I just want to touch on some of the surgical interventions you do. So let's just talk about hip fractures. What do you do as an orthopaedic surgeon with hip fractures? How do you fix them?
So it depends largely on two things. One, what type of fracture it is, and two, what type of patient it is. So our goal of surgery, independent of what we do, is we want to perform an operation on this patient that will allow them to mobilise immediately. Like the day of the operation, we want to get them up and walk, because we know that bed rest for elderly patients is a terrible thing to do to them. So whatever operation we do, we want to be able to get the patient up and walking immediately. So we can either fix it or replace it. So sometimes when you break your hip, which is a ball and socket joint, the ball may lose its blood supply and die unless you replace it. So we do either half or a total hip replacement, and that depends on whether the patient's been independently mobile previously or whether they're wheelchair bound. So I'd say about 2/3 of the time we do an operation to fix the bone, so put the bone back where it should be and fix it with either a plate and screws or a nail, or we replace the hip, either half the hip or the total hip.
Yeah, and is that also dependent on how young the patient is too? Are you sort of more inclined to do is there any change if they're really young? Does that change how you'd manage them?
For sure. So if the patients, ideally we'd leave every patient with their own bone. We wouldn't replace with a metal ball if we didn't have to. So if the patient is young, we do everything we can to keep their own bone. So we would fix it and just cross our fingers that it all healed. And if the patient's really elderly, again, you only want to do one operation on a really elderly patient, because, as you'd know better than me, giving elderly patients multiple general anaesthetics is not in their best interest. So we ideally do one operation. So in an elderly patient, we have a lower threshold to just replace the ball, because we know that that is going to be a definitive operation. Whereas if you try and fix it and then it doesn't heal and then they need a second operation, that's probably not in their best interest.
Yeah. Yeah, no, well said. So we've got Christo, we've got about 5 minutes left. Is there anything else on osteoporosis you wanted to talk about? Anything in terms of the orthopedic realm that is interesting, new or exciting? Anything else you want to think we missed that you need to touch on?
Not really, mate. I think it is certainly an important disease that's got a huge social and economic burden in Australia. And the problem with it, as we said, is it's silent. It often presents after an effect of it, such as a fracture has occurred. So it's something I think just to be conscious of if you're getting to that age group where your bone mineral density is at risk. Put in place those lifestyle interventions, as a preventative measure. So just have a look at your vitamin D and calcium intake, talk to your GP and get a very basic blood screen panel. Consider the type of exercise you do. If you do no exercise, just consider starting any form. And if you already exercise, just think about the type of exercise you're doing and what you want to get out of that exercise. Because one of the things in my mind you should want to do is prevent osteoporosis and therefore prevent falls, and therefore prevent any pathologic fracture, which will have a positive impact on your longevity and your lifelong prognosis. And feel free and have a low threshold to talk to your GP or talk to a dietitian or talk to an exercise physiologist or just people that are experts in this area. Because as much as I love my job, you want to avoid meeting me as much as you can, because if you've met me, it means you've broken something, which is a problem. It's good for me, but it's a problem for you.
And then you have to come and meet someone like me too. It gets even worse. Your day ends up terrible. No, that's all good advice, mate. So just in summary, just looking at those lifestyle factors, if someone came to you and said, I want to do everything I can. I'm 40 years old. I'm female. How am I going to prevent osteoporosis? What are you going to say to them? Rapid fire.
So don't cease smoking. If you smoke, that's a risk factor. Consider hormone replacement therapy, or at least talk to your GP if you're postmenopausal. Optimize your BMI, so don't be underweight, just be a healthy weight range. Start exercising or modify your exercise with the goal of preventing osteoporosis, and see a health professional if you're concerned at all.
Yeah, right. And just on exercise, would you recommend weights and cardio?
Yep, so a mixture of all of those. So the exercise science guidelines at the moment are exercise 4 to 7 times a week. So, and a mixture of load-bearing exercise, so something like, box jumps or just jumping in the air, or weight training, which can be multiple joint exercises, and then falls prevention, so yoga or Tai Chi, or just a mixture of all three.
Perfect, mate. Well, that brings us to the end. It was unreal to sit down. This is literally one of my first podcast recordings. So you were clearly always going to be one of the first. And I'll have to get you back at some stage. We'll talk about arthritis and we'll talk about a few other things. But, mate, just want to say a big thank you. I think, like you said, this is the silent disease. And it's just really nice to be able to sit down with like-minded humans and have a chat about it, because quite often that science communication, I feel like, gets lost between the medical realm and also and just everyday people. So this is what this podcast is going to be about, is just trying to connect everyday people with a health professional like yourself and hopefully make a difference in someone's life. And no doubt you have, mate.
Thank you, mate. Thank you kindly. My wife's the best. She tells me that communication is the key to any good relationship. We're not the best communicators, so it's
so true, mate. That is so true. Doctors, we're terrible at it. But thank you very much, mate. We'll catch up with you soon, all right?
Thanks, mate.